Let's see. Is it gonna work? Is it gonna work? I think it might work. Alright, this is my last try. This is it. This is all I'm trying. If it doesn't work, I'm done. I'm not doing it anymore. So here we go. I'm almost I'm almost tempted to just sit here for a second and not start talking because if it's not gonna work, I'm not interested in talking because I've already kind of discussed a lot of this stuff to myself. And actually, it would feel really good to talk about it and be able to go back and kind of listen to myself chat to myself. But if my stream's not going to work, I'm not I'm not going to do it. All right. So, let's see. Maybe it's working. Maybe it's working. All right. I'm going to say yes. I'm going to say yes, it's working. Here we go. And maybe I think I have okay. I have this. I'll put a link to the article that I'm discussing regarding AMI-CS, AMI-CS, acute myocardial infarction, cardiogenic shock. And what I'm reading is from the Journal of American College of Cardiology, the JACC, JACC. And this came out October, what did I say? October 8th, 2020. So just last month this came out. And it's titled A Standardized and Comprehensive Approach to the Management of Cardiogenic Shock. So this is really helpful for me um, because, going into the cath lab, there wasn't really, you know, what we do, right, in our cath lab and like what what is our standard and it doesn't really differ from this. I think we do exactly what this says, but there's very little there's no like cardiogenic shock bundle, uh, like a sepsis shock bundle, right? So you have like sepsis bundle, and it's like a big criteria that they have to meet. It's like WBCs are above 14,000 or less than 4,000 or something like that. SPB less than 90, tachycardic. Their temp can be high or low. Um, I think tachypnic or a source or something like that. And then you get, there's a whole protocol. You give 30 cc's per kilo crystalloid bolus, and then you get, you get cultures from two separate sites. You give broad spectrum antibiotics, and blah 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 blah. So that's the sepsis bundle. Um, Cardiogenic shock, someone in cardiogenic shock we don't have a bundle. You don't come in and you're like, okay, do this every time. Cardiogenic shock is one, it's way more deadly. I think if you come in, so mortality rates of cardiogenic shock are greater than 40%. So it's almost a flip of a coin. You come in cardiogenic shock, and it's a freaking flip of a coin if you're going to survive or not. Whether we do everything we can for you. So it's high mortality rate. Also, there's different phenotypes or presentations of cardiogenic shock. You can have right-sided heart failure, left-sided heart failure. You can have hypertensive heart failure. You can have hypotensive heart failure. I mean, you can have, so there's just a bunch of, you can have ejection fraction can be intact, can be not intact with your heart failure. So all these things can have a huge impact on our course that we go down when we are deciding what our next steps are. Being able to, and the thing too is someone comes in, they're having an MI, so they're having a heart attack. The heart attack needs to be fixed and we need, at the same time, we need to resuscitate their heart, right? So like we need to support we need to have some cardiac support, whether it's pharmacologically. And sorry guys, if so, hang on, time out. I'll just, all the sound that I'm yelling over. We just, my daughter and I think this is the first time she's just turned 5. I think this is the first time she ever put the dishes with me, put all the dishes into the dishwasher. So that was great. And so that's why the dishwasher's running, because it's full of dishes with my daughter before she went to bed. We did the dishes. So that's why that's running. I'm not going to stop it. And if no one wants to watch this because they have to hear me yell over this, that's totally understandable. Totally get it. That's okay. Um, so So, being able to diagnose what the problem is, being able to recognize cardiogenic shock, being able to intervene, I'm a little bit tired, intervene before they deteriorate. All these things are kind of tricky. It's kind of hard to do. It's kind of difficult um, because one, they crump really fast. Two, uh, it takes a team of people. It's not just like one person can do this from the start. From the EMS all the way to the ER to the cath lab to the ICU. There's a huge team that has to all function properly. If you get, if they're having an inferior MI and in the field is not diagnosed properly, and they're, preload dependent, and you give nitro and you dump their preload, and then they become hypotensive, you know, by the time you get to the ER, now their blood pressure's low. Now they're flooding them with fluid. Now they're going to be fluid overloaded, right? So they may be put on pressors. They may be intubated. They could potentially be, um, going into left heart failure after they've overloaded them with the right. So you have this like deterioration. By the time they get to me in the cath lab, they've gotten way too much fluid. There's no room for me to go. I have to diurese them before I gave any fluid. I have them on pressors. Now we're putting in a impella, right? And while we're trying to fix and reperfuse the tissue, depending on if it's viable or not. And then if we are able to get out of that, right, and we're able to offload the heart, if it's an RV failure, if we're able to offload the right side of the heart, or if it's a bi-V failure, we're able to offload the left and right, and we have impellas in, right, left and right impellas in, where trying to reduce the workload of the heart, increase the oxygenation, we've reperfused the coronaries, and now they're going to the ICU, and now we have to wean them off of that. You know, the whole thing is crazy, um, and so this is kind of why standardized care, cardiogenic shock standardized care, takes a lot of thought, because you have to differentiate what kind of heart failure they're having, and you have to determine what to do with that specific heart failure. Um, and so, I guess pulling from this, just my thoughts, one big thing is, you know, going, jumping to levo. So if their tank is full, if they've gotten enough fluid, their end diastolic pressure is high enough, greater than 10. If their end diastolic pressure is greater than 10, if we can get, and okay, so let's back up. The issue is a lot of times with these caths, we're not going in and getting a V-gram before we start fixing stuff. We just go straight to fixing stuff. So, and we haven't done an echo. So I don't have an end diastolic pressure or an LV function or ejection fraction, right? So if I'm coming in, I got a patient on the table where, we're about to get going and cath them, and I don't know what their ejection fraction is or their cardiac function, left ventricular cardiac function is, and I don't know what their end diastolic pressure is. I don't know their fluid volume, and I don't know how much kick they have in their LV. If I don't know either of those things, I'm pretty much going in blind. with what to do. If their blood pressure is low, their blood pressure is low. Um, you know, it's kind of sucks because you can push someone over into like uh, pulmonary, flash pulmonary edema, or put too much stress on their LV by giving too much fluid really quickly. And a matter of 250 mLs of fluid could potentially, depending on where they're at in their fluid volume, could potentially push them over, right, on that Frank Starling's curve, right? So if we talk about Frank Starling's curve, it's that like curve, the rubber band. However, rubber band stretches, the more you stretch, the better it snaps back to a point. If you stretch it beyond that, like that bell curve peak, once you stretch it beyond that, the snap is actually weaker. So you can put them into heart failure by giving them too much fluid. Their heart is too stretched out. They're not able to squeeze the blood out of their LV is the most important because LV is going systemic. I mean, RV is important too, but I'm concerned about LV usually. So I'm concerned about both. But when we're talking about blood pressure and we're talking about systemic perfusion, brain perfusion, kidney perfusion, we're talking LV pressure, right? So I don't have an end diastolic pressure. I don't know their fluid volume. If I don't have an ejection fraction, I don't know their LV function. If I don't have those two numbers, I just have to go off of blood pressure, right? And a mentation, basically. Or if they haven't been sedated and they haven't been intubated. So if they're awake and alert, I can see are they and what their skin looks like. So look at their skin, right? Is it cool, clammy, cool, pale, diaphoretic? Are they altered a mental status? And what's their blood pressure? And is it narrow? Is it a narrow pulse pressure? Do they have a good, strong pulse, bounding pulse? Is it weak and thready? I mean, generally, you're just gonna. I mean, you kind of have to just assume until you get your information what to do. But the best first move is determine have they gotten fluid, right? Get a history. Did the paramedics give her fluid? Yeah, they got a bolus. They got a bolus of 1,000 liters, right, or 1,000 milliliters in pre-hospital. Okay, then they may not be tanked up, but at least there's something in the tank. Did they get any fluid in the ER? Yeah, they got another half a liter, and it's still running. Okay, so if they've got fluid, if they got a liter and a half, yeah, maybe they're not totally tanked up, but they got enough to start pushing pressors, in my opinion. So basically, and this is where it gets confusing for me. It's hard. It's really hard. Levofed is like for our protocols and how we roll. Levofed. Start with Levofed or neuroepi. Neuroepi is like epi, but it doesn't cause as much beta 1 agonism, so it's not going to cause tachycardia as much. Tachycardia is giving just straight epi. So it'll increase your blood pressure, but it's not going to increase your heart rate, which is good because you don't want to increase the oxygen demand. Tachycardia is going to increase your oxygen demand. So you want to give a good squeeze on the vessels to increase your perfusion to the brain, increase your perfusion to the coronaries, right? We're really concerned about coronary perfusion pressures because when the coronaries stop getting fed, the heart starts to die faster, right? So we're worried about the brain, we're worried about the kidneys, we're worried about the heart. We're really worried about the heart because that's what's. I mean, I'm worried about all of it, but the coronary perfusion pressure is super important. And what's a coronary perfusion pressure? So coronary perfusion pressure is your diastolic blood pressure minus your end diastolic pressure. So your EDP minus your DP. And let's just confirm that. I believe that's correct, but let's just check. Normal coronary perfusion pressure.
According to LWW journals, Wolters Kluwer, studies in adult patients report a normal coronary perfusion pressure of 60 to 80 millimeters of mercury.
Okay. So 60 to 80 millimeters of mercury. So now let's say, how do you calculate a coronary perfusion pressure? Okay, I'm looking it up. Yeah. Okay, so diastolic blood pressure minus your pulmonary capillary wedge pressure. Your pulmonary capillary wedge pressure and your end diastolic pressure should be the same as long as you don't have mitral regurg. If you have mitral regurg and you have blood flowing during that LV contraction, you have blood squirting out your mitral valve, you can increase wedge pressures. So I just take an end diastolic pressure. Your wedge pressure to your end diastolic pressure to your CVP should all generally be about the same, right? So like 7 to 12, ideally. So you just take your diastolic. You can subtract your wedge, but I like to subtract the end diastolic pressure. It doesn't really matter. I think it's the same. Let's see. Coronary perfusion pressure. Open anesthesia. Left ventricular coronary perfusion pressure is the pressure gradient that drives LV coronary perfusion supplied by primary by the LAD and circumflex territories. It is defined as your aortic diastolic pressure minus your left ventricular end diastolic pressure. There you go. So your LVEDP, yeah, LAD, so that's exactly what I just said. So, and I have it right here. It says coronary perfusion pressure equals your diastolic pressure minus your left ventricular end diastolic pressure. So, and generally you want it 60 to 80. So if they have a diastolic pressure of 60, and you have an end diastolic pressure of freaking 25, what's that? 25 minus 60 is going to be 35. So 35, 45, 55. Yeah. So 35 on your coronary perfusion pressure is not high enough to be perfusing your myocardial tissue. So you need to, so that's the thing is kind of dictating. Okay, is my heart being fed enough oxygen? What's the oxygen saturation, right? Because we have to make sure that the hemoglobin is saturated with oxygen. If not, we need to give more. So 100% FiO2 to make sure they're getting enough oxygen in their hemoglobin. 1, to make sure it's perfused. 2, what's their hemoglobin and their hematocrit? Are they anemic? Do they have enough blood components to hold the oxygen? And if not, we need to give them blood. So like a stat H and H is like super important to know their oxygen carrying capacity. And then the third thing you're going to be concerned about is your coronary perfusion pressure, your diastolic minus your EDP, right? So kind of taking all that into consideration. Okay, um, if their coronary perfusion pressure is low as it is, freaking we need to get it up. So let's increase our blood pressure, right? So we're going to give something that's going to increase the squeeze on our blood pressure, or increase the contractility of your left ventricle to make sure you have more squeeze, and increase your blood pressure to make sure it's perfusing the coronaries. Now, this is a double-edged sword, right? This is where it gets really complex because increasing your blood pressure is going to increase your systemic vascular resistance, right? And so having an increased systemic vascular resistance is going to put more load on the heart because the heart has to work harder to push against that SVR. So you're kind of fighting a two-edged sword because you need a higher blood pressure to increase the coronary perfusion, but you need a lower blood pressure to reduce the workload on the heart because it's pushing against too much volume, right? It's pushing against too much pressure. So because it's making it work harder. So you have this battle. You have this kind of downward spiral of death, quite literally, where you're trying to increase the blood pressure, trying to reduce the workload of the heart, and trying to, in the middle of all of this, reperfuse and put a stent, right? The doctor's trying to put a stent in the coronaries that are blocked up to reperfuse the heart so that we can get more oxygen to it. So this is kind of the whole problem with cardiogenic shock. This is why the mortality rate is so high, is because when we go to try and fix the problem, what our interventions to fix the problem can cause more issues, right? Increasing your workload, increasing the SVR, increasing the fluid volume over what it needs to be. All those things will kill your heart. So it's a balance. Very strong, really hard. It's a balance. It's very hard. It's a very tricky thing. And so this is what left ventricular, they call them mechanical, what do they call them? Hold on, I'm gonna look at MDROs. What are they called? Hold on. They have like some fancy term. Um, let's see. When we get to okay, I just want to know this silly little acronym. It's just like an Impella or a Bi-V or a I'm sorry, Tandem Heart. Um, MCSDs. They're called MCSDs. That's such a little fancy name. MCSDs, mechanical circulatory support device. An Impella, or there's a big long list of different stuff. We don't use all this stuff. I wish we did because it'd just be that much cooler. But we don't. We use a few different Impellas, and that's it. We had an indirect balloon pump, which sucks. Here we go. So let's see here really quick. Yeah, so there's like really cool stuff. So you have an Impella RP, which is right side for right heart failure. You have a tandem heart RAPA. You have the VA ECMO, which is freaking sweet. We do not have VA ECMO, but that would be very cool. You have an intralock balloon pump, which is old school, and we don't really use those. And then you have the Pella 2.5, 5.0, a 5.5, and a CP, which is like a little higher than 2.5. So 5.0 and 5.5s Impellas, we don't use those because those have to be sutured in, and those are really for cardiac bypass and vascular open heart surgery. So when they have open heart surgery, they can suture it in right subclavian, I think, and you just suture it right in the right subclavian. And you just drop it right into the LV from there, and it supports like 5.5 liters per minute or whatever it is. So we don't have Impella 5 and 5.5, and then a tandem heart LAFA. So left atrial femoral. So I've never used a tandem heart. I've never got to do VA ECMO. Never used the Impella 5.5 or 5.0. All I've used is intra balloon pumps, Impella RP, Impella CP, and Impella 2.5s. So, but they still work. They're still really good. They're still amazing. But basically what we're doing is the whole goal of any kind of MCSD, mechanical circulatory support device. Any The reason we throw an MCSD down is because we know as soon as they get on pressors, we start putting them on levo, then we have them on dopamine, then we have them on dobutamine, then we have them on vasopressin, whatever. We have them just epi. We have them just cranked out on all these pressors, trying to keep their blood pressure up. We need to offload the heart, and we need to reduce the workload because the oxygen demand is the thing that's killing it, right? It's having to work harder, and so it's using more oxygen, it's dying faster. So by using a mechanical circulatory support device, we are reducing the oxygen demand, we're reducing the workload, and we're offloading what's called offloading the LV or offloading the RV. So we're pulling fluid from the ventricle into the system without it having to work at all for it. Intra-aortic balloon pump doesn't do that. Intra-aortic balloon pump, all it does is increases coronary perfusion pressure, and it reduces the workload. It still works great, but the Impella, it's just Impella just I don't know. It's I don't know. I like it more. So, anyways, it doesn't matter. The point is the next step, and kind of uh, in lockstep with starting levo, right? Starting dobutamine or dopamine or whatever. We are preparing to get an Impella thrown downstream, right? Impella needs to get on board because the sooner we offload the heart, the faster that heart calms down, relaxes, not having to work as hard, and now we can reperfuse it and we can give it some time to kind of um, kind of be stunned, because that's what happens when a heart's going to cardiac shock. The LV is stunned. It's not contracting properly. It's hurt, and so by offloading that, that is basically what we need to do, and then we hope that we can wean them off of the Impella and get them back into their normal function. If they're not able to, then they have to like do they have to what they got to get a new heart. You got to transplant. So or you have to get like an LVAD, a durable LVAD, left ventricular assist device. So and then there's also like VA ECMO, which is it's kind of like a bypass where we're bypassing the or well, I don't know if we're bypassing the lungs. No, I guess we are. VA ECMO is bypassing both lungs and the heart. So, anyways, that kind of shuts everything down, allows it to all kind of rest completely, and then they try and bring them back on. It's like bypass or yeah, cardiopulmonary bypass basically. So it's like a perfusion machine almost. Anyways, so I guess let's just get back to some of these stats that I think are kind of interesting. Um, so, so that's kind of the conundrum that I've experienced with cardiogenic shock. Let's see, highlights. Cardiogenic shock is a hemodynamically complex multi-system syndrome associated with persistently high morbidity and mortality. Yeah, so there's like a whole nother. I haven't even talked about the physiologic. I've just talked about the interventions that we do that cause the problems. On top of the interventions that we do that are causing these problems, physiologically, there's a cascade of events that are taking place with the renin-angiotensin aldosterone system, and with catecholamines being released, and like cytokines being released, and all these different chemicals that are increase the workload on the heart. It's a preservative mechanism, but it ends up becoming detrimental, causing more problems. Let's see what else do we got here. What else? Let's see. Short-term mortality from cardiogenic shock is greater than 40%. I said that already, which is kind of crazy. Purposes, pathways of contemporary cardiogenic shock care. That's fine. Another big thing, yeah. So another big thing would be like getting a pulmonary artery catheter in. So a Swan-Ganz catheter. Oh, is it dead? Oh, look at this. I'm totally getting like a whole video in. This is great. Let's see. Hmm. Let's see. Epidemiology. No. Pathophys. Uh, all right, this is a great one. So send the central pathophysiologic derangements encouraging shock is diminished cardiac output, leading to systemic hypoperfusion and maladaptive cycles of ischemia, inflammation, vasoconstriction, volume overload, often culminating in multi-system failure and death. The initial cardiac insult may stem from various etiologies. We're talking about an acute myocardial infarction. Impaired cardiac output and progressive diastolic dysfunction raise ventricular and diastolic pressures. This is what I'm talking about, which reduce coronary perfusion pressure. This is exactly what I just said. Myocardial contractility and stroke volume. Okay. In response to tissue ischemia and necrosis, which is the tissue in the heart dying because it's all plugged up from a bunch of gunk, um, released inflammatory mediators further impair tissue metabolism and induce nitric oxide production, which causes systemic vasodilation and exacerbates hypotension. Okay, so there you go. That's a big one that I see, and this is like another stress stressing the already dysfunctional myocardium. This maladaptive response may be acute, or as occurs with acute myocardial infarction, cardiogenic shock, or superimposed on chronic neurohormonal activities that accompany this whole thing. Acute decompensated heart failure, cardiogenic shock. So ADHFCS, which is acute decompensated heart failure, myocardial cardiogenic shock. Hypoxia and pulmonary inflammation induced pulmonary vasoconstriction, increased biventricular afterload, and myocardial oxygen demand. The renal response to impaired glomerular filtration, increased tubular sodium reabsorption, and activation of the renin-angiotensin aldosterone axis, resulting in further volume overload and compromised diuretic effectiveness. All right, so that's the thing is you have so that's where I'm a little confused. So I'm not confused now; it's more clear. Um, so you have this renin-angiotensin aldosterone system that's causing sodium reuptake, which is increasing your fluid volume, and then you have these inflammatory and necrotic mediators that cause vasodilation. So as you vasodilate and you're reabsorbing fluid. And now we're throwing boluses on top of that. Your diastolic pressure, as your blood pressure is lowering, you're reducing your coronary perfusion pressure. And this is when people code. Like you watch it get sluggish. It becomes sluggish, more sluggish. You're watching on the monitor and they're going to inject, and we see that they're not clearing the contrast fast. That means their coronary perfusion pressure is dropping, and soon the heart's going to stop getting enough oxygen, and it's going to code. And this is bad news bears. This is where the game ends. Sympathetically mediated splenic vasoconstriction further worsens volume overload by redistributing 50% of total blood volume back into circulation. Augmented ventricular filling pressures further worsen myocardial efficiency and ischemia, especially within the right ventricle. Left unabated, this maladaptive cycle often progresses to death. So that's really kind of exactly what's happening. Low output state stemming from primary cardiac dysfunction, resulting in hypotension and systemic hyperperfusion. Let's see. Okay, so I like all this. This is really good. Definitions and classifications. So I think I'm getting tired. Maybe we'll make a two-part series. Maybe this will be the next. Maybe this will be the next one, right? We'll do another part to this when I start to talk about, because we're at 30 minutes, clinical trials and societal guidelines, definitions, classifications. So we'll get to definitions and classifications next, and then we'll start we'll just keep going through this thing. So that's where we'll go next. Definitions and classifications. So I guess that's what I got. I like it. This was fun. This felt right. Felt good. All right. Boom. That's all I got.